we welcome everybody to this. We're welcoming everybody now to the super user palliative care super user group educational offering, which we're going to try and do quarterly, and we're going to try and have CME attached to it too, because obviously that is beneficial for everybody, and we're super excited to have the team from Oxner. Susan, you want to introduce your colleagues?
Sure. Thank you for doing that. And have we found continuing education? Do we do that through
Yes.
LAFP? Okay.
Yeah, Marquetta did all that.
Great, 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 great. So yeah. So I know a lot of you on the call. I'm Susan Nelson at Ochsner Health, and I am fortunate to work every day with Dr. Barley Halton, who is trained, did the University of Queensland Medical School, and then psychiatry at Tulane, and then his palliative medicine fellowship at NYU. And he and Dr. Brand will talk about the things that they do. And then also, Dr. Kaylee Brand is an LCSW with also a Doctor of Social Work from Tulane, and she works with us to take the best care possible of the patients that we are privileged to see. And so with that, thank you, Barley and Kaylee, for being on this call.
All right. Well, we are going to kick off our presentation for y'all today. So again, hello, my name's Kaylee. I am a clinical therapist at part of the palliative medicine team at Ochsner Main Campus. Dr. Barley and I are going to talk today about a topic that often doesn't get enough attention, mental health and palliative medicine. In our work every day, we see how the psychological well-being is deeply intertwined with a patient's physical health, their ability to manage their symptom load, and just their overall quality of life. Next slide. So,
oh, sorry. There we go.
Today we're going to talk about these three objectives. And so first, we want to look at the importance of recognizing and addressing the mental health needs of our patients with serious illness, why this matters, and how it shows up in our population. We then want to touch on the role of psychotropic medications in managing the mental health symptoms that our patients experience. And then we're going to go into depth on a couple evidence-informed psychotherapy modalities that can really be utilized often in time-limited or adapted forms for our population. So why mental health and palliative care matters? So clinically significant psychological distress, this affects 1 in 4 palliative care patients. And we know that this is likely underestimated. When this is left unaddressed, this distress, it doesn't just impact an individual's mood, it can also impact their pain management. It can make communication more challenging, both with their support system as well as their providers. And it ultimately worsens their quality of life. When we think about what psychological distress can be associated with, it can be associated with an increased mortality, a faster physical decline, and individuals can experience more suffering. Also want to highlight that it can lead to non-compliance with treatment, especially if a patient is feeling hopeless, overwhelmed, or just unheard in their treatment planning. When we think about the values and the goals of palliative medicine and the care we provide, addressing emotional distress is a vital component of what we do. So here on the screen are just, I would say, the top mental health complaints that we see, but it is not an exhaustive list. Depression is prevalent, and it can look very different in medically ill patients. Sometimes depression in this population, it's more about withdrawal, fatigue, or hopelessness, rather than maybe that what we consider that stereotypical sadness associated with depression. So when we think about suicidal ideation, this can come up, of course. And what's important is that we distinguish this from a desire for hastened death, which that is a form of existential suffering. All right, so these aren't the same, therefore deserve different responses in how we support that individual. We frequently see adjustment disorders, especially shortly after a new diagnosis or a major health decline, as well as anxiety. This could be generalized anxiety or more focused around uncertainty or loss of autonomy or control. You also see, of course, insomnia and substance use disorders when related to their chronic or terminal illness.
So, despite the prevalence of mental health conditions within this population, there still exists a lot of barriers to mental health support within palliative care as a whole. For example, normal grief versus depression. There's this mentality of course you're sad, you have cancer and you should be. And certainly I've had patients that I've told what you're experiencing is normal and an expected part of the grief process, and no medicines are really going to help with that. That shouldn't be the default response, which seems to be the case. There's a lot of symptom overlap, which we'll go over shortly, between diagnostic criteria of mental health conditions and what we see commonly in our terminally ill population. There still exists a lot of stigma surrounding mental health, both among our patients and also, unfortunately, among many healthcare professionals. There's a prioritization of physical over emotional needs when patients come into clinic. There's limited mental health training for non-psychiatrists, although palliative care is a specialty you can go into from pretty much any residency with patient contact. The majority of providers come from a internal medicine or a family medicine background, where there may be some, but very limited mental health training. There's quite a lot of complexity involved in managing of psychotropics, which I'm sure many of you have experienced and therefore been quick to consult your psychiatry consult liaison team. And that leads to the next point, that there is a general lack of collaboration between palliative care and psychiatry, with the mentality that if one is involved, the other one doesn't have to be. So, going back to some symptom overlap for an example, this is an example that highlights some of those challenges. So here we have the diagnostic criteria for major depressive disorder as outlined in the DSM-5. In order for a patient to meet criteria for MDD, they need to have depressed mood and or anhedonia, or loss of interest in pleasure, plus 5 of the remaining 7 criteria for a minimum of 2 weeks. If we go through those criteria, weight loss and appetite change. That's something we see in pretty much every one of our patients, especially our cancer patients. Insomnia, hypersomnia, psychomotor agitation or depression, also things that we see in patients who are experiencing some form of functional decline. Fatigue, loss of energy, diminished ability to concentrate. That one you may be able to argue is more of a mental health more of a mental health symptom. However, many of the medications that we're prescribing patients can affect their cognition and, as a result, lead to loss of concentration. For example, we've all heard of chemo brain. And then lastly, recurrent thoughts of death or suicidal ideation. Recurrent thoughts of death are going to be common in patients with terminal illnesses, especially as they're coming to terms with their own mortality and constantly being asked about goals of care and what they would want at the end of their life. So these recurrent thoughts are expected. And so a patient, as you can see, there is quite a challenge here in making an appropriate diagnosis when arguably every patient that comes through our door, in theory, could meet criteria for MDD. So what are some ways that we can address that? So there are some unique differences when we go comparing normal or expected grief versus depression. So if we look at the nature of the response. In normal grief, this is considered an adaptive response, versus in depression, it's not serving the patient and it's actually maladaptive. Focus of distress in normal grief tends to be centered around loss or impending loss, and doesn't affect all aspects of a person's life. In depression, this tends to be more pervasive and does affect the majority of aspects of a person's life. In normal grief, this will present as coming in waves. It's often triggered by reminders of their illness or reminders of what impending loss, versus depression tends to be more constant and doesn't necessarily need a reminder. I will say, just before I continue, this is big generalizations. Obviously, every patient's going to be different, but these are some particular ways that you can take into account to differentiate between the two. Anhedonia, or loss of interest. This is in patients with normal grief, there tends to be a capacity for pleasure remains intact, and there's opportunities to be distracted from their grief. Whereas in depression, it tends to be a loss of interest or pleasure in all, if not most, of activities. Hope is generally preserved in normal grief versus not the case in depression. Self-worth remains largely intact in patients experiencing grief, and the instances that they are questioning their own self-worth, it's largely regret related, as opposed to depression can present more as low self-esteem and feelings of worthlessness. And then lastly, we have suicidal ideation, which in normal grief, especially in those grieving their own shortened lifespan, there may be this passive desire for hastened death. I would say that Dr. Brandt and I both, probably the majority of our patients, endorse some desire for passive hastened death, saying they wish this would be over, or sometimes they just would hope that things would hurry along. And that can set off alarm bells for people. And we've had patients in the emergency room who have been PEC'd or held on an involuntary commitment for suicidal ideation when they're just expressing a normal part of grief related to their terminal illness. And then in depression, where those patients do experience suicidal ideation, whether or not it's passive or active, there tends to be a preoccupation with a desire for death, wanting to die, and in some cases may progress to a plan on how they would end their life.
So when we think about the complexities in our population and how we're able to screen the symptoms that they're experiencing, here on the screen are a list of screening tools, both that are commonly used. I want to start at the top because, I would say the PHQ-9 for depression and the GAD-7 for anxiety are two of the most commonly known assessments. However, when we are addressing and screening the symptoms of mental health and palliative care, like Dr. Halton was discussing, these really all include those somatic symptoms, so sleep, appetite, fatigue. And since we have that overlap with physical illness, it's not able to paint a really clear picture of what they're struggling with. The ESAS, this can be a great tool used for symptom tracking, but it's not validated for that in-depth mental health assessment. The bottom three, we start to move into kind of more appropriateness for our population. So we have the GHQ-12, the General Health Questionnaire. This is really kind of just looking at general psychological distress across multiple settings for that individual. Of course, we have the Geriatric Depression Scale. This is designed specifically for older adults. Therefore, it does have less emphasis on those somatic symptoms. And then the last one on the screen I find to be very useful. So it's the Hospital Anxiety and Depression Scale. And we're going to kind of go in a little more detail in a second, but it is common across medical settings and it excludes the somatic symptoms. One of the limitations is said that it can potentially miss some of the nuanced distress that a person might be experiencing. All right, so here you see the HADS assessment, the Hospital Anxiety and Depression Scale. This is a 14-item scale, and it is addressing 7 questions are addressing anxiety, and 7 are addressing depression, and it's excluding our somatic symptoms. It states that a score of 11 or more is typically indicates significant symptoms. This is short, it can be easy to administer, and what's great about this is it can be repeated to show changes over time. So this is the distress thermometer. I will admit this out loud. I just discovered this tool pretty recently and find it to be wonderful for our population. I truly love it because it's visual and it's simple. So the distress thermometer, it was developed for oncology, but it's been widely adopted to other patient populations. And so what patients do is they rate their distress on that thermometer scale from 0 to 10. And then on the right-hand side, we have a problem list, and they're able to check boxes across different domains. So whether that's physical, emotional, spiritual, practical, this can really allow us to focus our interventions and treatments on these specific needs of that individual. When we're able to identify like which one of these realms the stressors they're experiencing are in. This can really normalize distress. Okay. All right, so kind of looking at that list of screening tools, it always raises the question of, is there something simpler? One option that we see utilized in primary care settings is the Woolley questions. And this is a 2-question measurement tool that's designed for both detecting depression in primary care settings. And so if you're short on time or just want a very quick screening, this can be a really good option. So the 2 questions are, during the past month, have you often been bothered by feeling down, hopeless, or depressed? I think what's really unique about the Woolley questions is if you're familiar with a PHQ-9, the wording is over the past 2 weeks, how often have you? And it's wanting a more of a quantifying, it's not at all, often, very often, nearly all the time. But by just saying, have you often been bothered by feeling down, hopeless, or depressed? Or have you often been bothered by little interest or pleasure in doing things? Answering yes would warrant further assessment and evaluation. Answering no to both questions has a high probability that depression is unlikely. And so this can be great to be used at bedside if energy is limited. It's keeping it short and sweet, and then it opens the door to a further conversation if yes is the answer.
So even with these improved screening tools for mental health conditions, it's still important challenges to consider specifically for this population. So we'll go through all of these in a little more detail in a second, but for example, delayed onset of action. The majority of psychotropics take between 5 and 7 weeks for them to reach their full therapeutic effect. Our population may not have that luxury. They may have a limited life expectancy, or even if they have a couple months to live, there's no guarantee that the first trial of an antidepressant is going to be successful. And then you're just exposing them to potential side effects and would have to change course after a month or two, and that medication may not be effective either. Also important to consider medication side effects. So our population is already very prone to this due to high rates of polypharmacy. And just in general, the majority of the patients we see tend to be on the older side who are more susceptible to developing side effects from medications. This polypharmacy, as already mentioned, leads to increased risk of drug-drug interactions. And then we have also an effect on the pharmacokinetics and pharmacodynamics in of psychotropics when we're dealing with patients with organ failure. So going a little bit more into the delayed onset of action. So I already mentioned about the challenges of this. So a way that I tend to approach it in my clinic is to have more of a symptom targeted approach. If I'm going to expose a patient to a psychotropic that may or may not be effective at managing their mood symptoms, I'm going to try use the side effect profile of the medication to at least have some benefits. So let's say I have a patient who is coming in reporting depression and also significant fatigue. That may make me more likely to prescribe something like Wellbutrin or an SNRI, which could have some stimulating like properties to kind of give them that boost in the morning. Um, if I have a patient endorsing a poor appetite, so we all know about mirtazapine. It's very commonly used in palliative care for this reason. Many of you may be aware of the more recent data that's come out suggesting limited effectiveness at actually improving appetite and certainly does not improve weight. That being said, anecdotally, having been prescribing this for several years now, I find that the majority of my patients who do take mirtazapine report improvements in appetite, or rather actually complain about eating too much after starting mirtazapine. So I continue to use it for that reason. Additionally, you could also use some of the second generation antipsychotics. Olanzapine or Zyprexa, for example, has been shown to boost appetite and also increase weight. One study showed that 60% of in a controlled trial, 60% of patients who were taking Zyprexa saw a 5% or more increase in weight gain versus 9% of those who were in the placebo group. Insomnia, we could use mirtazapine again, which has more of a sedating properties. I may be more likely to use benzodiazepines in this population for insomnia, which I certainly would not do in somebody without a life-limiting or terminal diagnosis due to risk of abuse or developing tolerance over time or dependency, or neuropathy. Use of our SNRI agents like venlafaxine or duloxetine can be helpful. Gabapentin has also been shown helpful in mental health conditions. We commonly prescribe it for neuropathy, but it's been shown effective in managing anxiety. It's also been effective in helping with insomnia at night when prescribed in higher doses. So this is a medication that I actually use a lot more in this population for psychiatric related issues than I do in my general adult population without life-limiting illness. Then there are the possibility, if you have access to these, of rapid acting alternatives, also known as interventional psychiatry. ECT, TMS. TMS stands for transcranial magnetic stimulation, which we actually have a clinic here at Oshner main campus that does this. And I'm in the works of talking to the attending who staffs this about maybe collaborating and having more readily access to our patient population. Ketamine. This is available in IV in some places, such as St. Charles Parish Hospital for refractory depression. And then there's also S-ketamine, which is the intranasal version approved by the FDA. Psilocybin, a lot of great research coming about its effectiveness, specifically in our palliative care population. Unfortunately, it's still in the clinical trials phase and only available at select institutions around the country. But in the coming years, I suspect that this is going to be widely used. And then we have our non-pharmacological interventions, music therapy, acupuncture or massage, and then, of course, psychotherapy, which Dr. Brandt will go into in more detail. So a little bit more detail on some medication side effects. So even when we decide that psychotropics are appropriate, we have to weigh the risks carefully. In our population, side effects aren't just nuances, but they can seriously worsen somebody's quality of life or mimic other issues that we're already trying to treat with other medications. SSRIs or SNRIs, for example. These are often first line and for good reason. They are generally well tolerated. and they are the most studied in a wide array of populations. But even with these, side effects like nausea can be a real issue, especially in patients who are already taking medications such as chemotherapy agents, which could be worsening their nausea. Sexual side effects or sexual dysfunction. Most common in SSRIs and SNRIs out of all of the psychotropics. Worst offender of all of them is paroxetine. This is something that we do not screen for routinely enough, and is something that can have a significant impact on one's dignity, also on one's interpersonal relationships and sense of identity or self, especially driving an additional wedge between a patient and their romantic or sexual partner. Tricyclic antidepressants. Although these are rarely used first line in psychiatry due to high burdens of side effects and overdose risks, they're used a lot more commonly in palliative care and often used off-label to treat things like insomnia or neuropathic pain. The class especially heightens risk of adverse events in our population, such as anticholinergic effects. Majority, I would say, of drugs that we're prescribing have some anticholinergic effects. So this is just an additional medication that could be worsening that. QTC prolongation, we see that in a lot of our medications, such as Zofran for nausea, but also some pain medications such as methadone. Orthostatic hypotension is also a concern that we have. Mood stabilizers, which may be added for agitation or behavioral disturbances when antipsychotics are contraindicated or not tolerated. The big worry I have when prescribing this class in our specific population that is often overlooked is actually fluid shifts. All of the mood stabilizers we have currently act on sodium channels. And as we know, sodium is essential to maintaining appropriate fluid status. And so if you've got a patient with CHF or renal impairment who already are prone to these imbalances with their fluid overload, this could exacerbate that, especially if they were to become dehydrated or a decrease in their PO intake. For our antipsychotics, can cause sedation, which can be both therapeutic and also potentially problematic if they're taking several other medications that are already making them feel overly lethargic. This is especially more likely when combined with other medications, opioids, gabapentin, benzodiazepines, things that we commonly prescribe in our patient population. Also comes with the added concern of anticholinergic side effects, QTC prolongation, and can be particularly deliriogenic. Our benzodiazepines, I think that most people are probably familiar with these side effects: excessive sedation, theoretical respiratory depression when combined with opioids, and it can also potentially have a paradoxical reaction causing paradoxical agitation in somebody. And then lastly, we've got our psychostimulants. These include things like Adderall, Vyvanse, Ritalin, and although they can be helpful in boosting someone's energy level, they can also worsen someone's anorexia. They can worsen somebody's insomnia, especially if taken too late in the day, or if a patient is overly sensitive to stimulant-like medications, and similarly can worsen someone's anxiety, irritability, or even agitation. So polypharmacy, as I've mentioned at various points, is pretty much an expectation in palliative care. And for this reason, it's important to not overlook drug-drug interactions. We should be taking this into consideration with all medications that we're prescribing, but I'm urging you to pay particular attention when prescribing psychotropics. For example, bleeding risk. The combination of mirtazapine and warfarin. Mirtazapine actually prevents the breakdown of warfarin and increases its anticoagulant effect. SSRIs and SNRIs, which we pretty much throw around all the time, have antiplatelet effects. And so when combined with an antiplatelet or even an anticoagulant can increase somebody's bleeding risk. This is particularly concerning in patients who may have mucosal tumors or urological tumors who are particularly prone to increased vascularization and excessive bleeding. Metabolic interference. So the cytochrome P450 enzyme system within the liver is actually responsible for breaking down the majority of psychotropics that we have. Medication, and this can be particularly concerning when you have disease-directed treatments that also interfere with that same system. For example, fluoxetine and paroxetine are both they are both cytochrome P450 inhibitors that prevent tamoxifen, which is a prodrug, from being broken down into its active metabolite. Not too long ago, I had a patient who was referred to me for depression, who was taking paroxetine combined with tamoxifen, and one of her big stresses was she did not understand why she was continuing to have disease progression despite taking her cancer treatment. Someone at some point had prescribed the two together. I'm not saying that that was the cause, but it certainly didn't help the situation. And then also take consideration prodrugs. So prodrugs are medications that need to be broken down into its active metabolite, mostly done by, again, cytochrome P450 agent or enzyme system. Examples of prodrugs that we're going to encounter often include codeine, tramadol, hydrocodone. There was actually a study done outside of palliative care, done by surgery, of all people, who found that when treated with these prodrugs, patients who were taking a SSRI or an SNRI had worse pain control and required increased doses of opioids throughout their acute period post-operatively. And then we have also some cardiac risks. So already mentioned that lithium, along with the other mood stabilizers, acts on sodium channels. When combined with diuretics, this can cause worsening of fluid shifts. And then there's QTC prolongation of many of our medications that we already went through, antipsychotics, for example. And this is particularly concerning in patients who have an increased cardiac risk. Beyond drug-drug interactions, special consideration should also be taken for patients with organ failure, which is a common issue that we deal with in our palliative care population. This can have effects both on the pharmacokinetics as well as the pharmacodynamic interactions of these medicines. For example, liver failure. If somebody is having liver failure, that means that their cytochrome P450 enzyme system is likely not operating as it's supposed to. This can lead to decreased breakdown or metabolism of various medications, including tricyclic antidepressants, our serotonergic agents, benzodiazepines, with the exceptions of three medications, lorazepam, oxazepam, and temazepam, which are the only benzos that are safe to be used in patients with liver disease, can lead to accumulation of some mood stabilizers as well as clozapine. This accumulation increases the risk of side effects and can have disastrous outcomes. So increased serotonin lingering can lead to serotonin syndrome. Clozapine lingering increases the risk of agranulocytosis, which is particularly concerning in patients who already have a weakened immune system, as many of us do. Liver failure can also, so our medications that we prescribe can also worsen liver failure. Those that are particularly bad for hepatotoxicity include valproic acid, which carries a risk of acute liver failure, carbamazepine, which results in cholestasis, which can worsen or exacerbate liver failure, and duloxetine as well. In our renal failure patients, we have decreased clearance of medications like lithium, which will accumulate and then actually exacerbate renal failure. We can have decreased drug clearance of gabapentin, which is something I saw recently actually in an ICU patient who was in acute renal failure and had been stable on their dose of gabapentin for many years and developed gabapentin toxicity and oversedation. Duloxetine, another medicine, can cause can accumulate in our renal failures and lead to serotonin syndrome. Several medications are nephrotoxic, lithium, valproic acid, and then we go to our heart failure patients. So there's a decrease in cardiac output in these patients, resulting in decreased perfusion of the liver and the kidneys, which can mimic liver failure and renal failure, or at least they're not operating as well as they should be. Fluid overload, we've already referenced several times, and from a pharmacodynamic standpoint, we have medications that result in QTc prolongation, which can exacerbate heart failure, as well as orthostatic hypotension, including tricyclic antidepressants, as well as prazosin. So, understandably, managing psychotropics in this population can feel overwhelming and also daunting. So, here are some practical tools and reminders to help guide you. So, make sure that you're checking your dosing adjustments in any of your patients with organ dysfunction. Key resources that you can always consult for this, but also for any other questions you have, include UpToDate, but also the Psycho-Oncology Journal, which is a great resource if you're interested in diving further into the complexity of psychotropic management in palliative care. It's important to consider prognosis and life expectancy when prescribing medications with delayed onset of action. Otherwise, you're just exposing them to side effects without any chance of benefit. And and also you can always collaborate with a mental health professional.
All right, and that transitions nicely into our discussion on psychotherapy and then some specific modalities. And so that collaboration piece has been what's been so nice working with Dr. Halton as a therapist, because we have the ability to address psychotropic medications when applicable and then make rapid changes as symptoms progress. From a therapeutic standpoint, psychotherapy can be a vital component. It's not just an extra service when time allows. Many of the emotional responses that we see, whether that's grief, anxiety, or maybe some identity shifts, these are all rooted in an individual's life circumstances. It's not just a neurochemical imbalance. And so while psychotropic medications can absolutely be beneficial, like Dr. Halton was saying, they can have limited effectiveness, whether that's due to time or just availability in terms of the symptoms being experienced. Another reason psychotherapy is important is that the impact can sometimes be immediate. You know, even just 1 or 2 sessions where a patient feels truly heard and seen can really reduce distress and shift how they experience their illness and that illness identity. Psychotherapy, it also comes with fewer risks and side effects, which can be particularly helpful when managing polypharmacy or frailty in our patients. And then lastly, psychotherapy really supports a collaborative person-centered approach. It really focuses on honoring the patient's voice, identifying what their values and priorities are, and working to restore that sense of agency during a time where all of my patients feel a loss of control, a loss of autonomy and independence. So here on this slide are some common psychotherapy interventions that can be effective and utilized in palliative care. The 4 that you see on the right, on the left, CBT, motivational interviewing, behavioral activation, and supportive therapy are highly adaptable, which can be really great for our population depending on that time constraint. Whether we are faced with limited time, limited energy of a patient, or cognitive limitations, these 4 therapies can be used in a briefer or modified format to really kind of meet the patient where they're at. With motivational interviewing, This is a really great way to kind of gently explore ambivalence in patients when they're facing complex decisions. This could be whether to continue treatment, whether to enroll in hospice. Behavioral activation, this can, an example of this would be maybe helping a bedbound patient engage in something meaningful, identifying what activities they enjoy and how can we adapt them to their current abilities. That's something I do frequently in therapy, is shifting the language from identifying it as a limitation to identifying what we can do within our current abilities. I have a patient who recently had a series of bad falls, and it really set him back mentally because he saw the progress he had been making in terms of his ambulation. And when we met after his fall, he discussed how he had set the goal that every commercial, he would use his walker, get up from his recliner, and if all he could do was stand during that commercial, then he would. But what he noticed is he started walking across the room and back at the next commercial, and then working to walk to the kitchen. And so recognizing that even within, if we are chair-bound, if we are bed-bound, seeing how we can incorporate the activities into our daily life. Supportive therapy, of course, remains essential and is a part of all psychotherapy that's provided. This is just offering presence. It's offering validation and space to process. The ones on the right, we're about to go over in detail because I think they are some wonderful options that are more structured therapeutic interventions. All right, so first we're going to talk about acceptance and commitment therapy, also known as ACT. And so the core philosophy of ACT is that, pain is inevitable, but suffering comes from our own struggle against it. This can really resonate deeply in palliative medicine. ACT can empower agency, especially when circumstances feel uncontrollable. Thinking of that patient that we've had that says, just what's the point? What's the point in going through treatment? What's the point of every day? And so in ACT, that first step is acceptance. Like, it is acknowledging the emotions. It's allowing individuals to experience the feelings of grief, of loss, of fear. And then when you kind of move down, we can see another key process, which is the values clarification. It's following up that what's the point with, what matters now? Bringing it to the present. And through reflection and discussion, what we can do is identify small value-based steps. Someone who was always a caregiver, who's unable to provide that care for others, might say, well, what's the point? And it is looking at ways to still provide that support and quote unquote help within their current state. It's helping patients kind of find ways to live meaningfully without suffering. I think one of the greatest struggles when faced with a life-limiting or terminal illness is psychologically, our brain wants us to do everything like we did before that diagnosis, before that progression. And so with acceptance and commitment, it is accepting where we are at, identifying what matters most, and then working to incorporate that into our daily life. So here we have narrative therapy, and this really invites patients to explore the story they're living within. Oftentimes, serious illness, it becomes the dominant story. I can't tell you how many times patients say, I'm more than this cancer diagnosis, or I'm more than this heart failure. And so one aspect that I love about my job is I get to explore the multiple identities that each individual has. Through narrative therapy, the patient's the expert, not the clinician, not the provider. our role as a clinician is to externalize the problem. Saying things like, this illness isn't all you are. It's something you're navigating. Helping them verbalize what other identities they might have. The clinical usefulness that narrative therapy really has is that it empowers identity. It also can be deeply healing when patients might feel dehumanized by medical settings. I have patients who probably are at Ochsner Main campus every day as a part of their treatment sometimes. And they are surprised and also really enjoy when we have a session that talks about a version of who they are that has nothing to do with that diagnosis. You can see the both verbal and nonverbal responses that they have. All right, so dignity therapy is very brief, just 3 sessions, but it is a structured life review process. This is often used near end of life, but can absolutely be applicable in an outpatient setting. And so dignity therapy, it really helps patients reflect on what gave their life meaning, whether that's roles that they've played, memories they treasure, values they want to pass on. As a therapist, I use semi-structured questions. They might be things like, what's the most important roles you've played in your life? And what I really like about dignity therapy is that it's not chronological. It's not asking an individual to go through every major life event that they've gone through. It allows the individual to focus on ideas, moments, important memories without necessarily reliving the pain. This can be a really powerful intervention, especially when an individual is struggling with maybe feeling like a burden. Being asked to share your story, it can really restore dignity and connection. It enhances that sense of purpose and generativity, which in turn can help reduce anxiety and depressive symptoms. When we think about the structure of dignity therapy, so those 3 sessions, session 1 is you're composing. So you're asking those open-ended questions and your patient is just allowed to answer in their own words. You are recording this session so that you can then have a transcript that can be utilized in session 2, where you and the patient work to revise that story and revise that document. And then the 3rd session is where it's presented to the patient and we're able to reflect. This can provide a tangible resource, not just for patients, but also their family members. It can reduce anxiety and depressive symptoms, and it can really help family members with anticipatory and post-death grief. Real quick, one thing that I'm hoping to utilize with dignity therapy is kind of the use of AI. We have some really great platforms out there that can produce transcripts of conversations. And so thinking about how this is already utilized in healthcare to use AI, this would be a seamless transition to be able to do dignity therapy, both virtually or in person with patients. All right, so meaning-centered therapy. So meaning-centered therapy, it is grounded in this idea that meaning can be preserved or even deepened in the face of suffering. It's based on the teachings of Viktor Frankl, Man's Search for Meaning. It's written from his experiences living in Nazi concentration camps. He states that human beings, that we create meaning through our choice of attitudes, even in dire life-threatening situations, that our ability to connect with life through art, humor, nature is a way that we create meaning. And that we create meaning through our understanding of our lived experiences. both the past, the present, and then what we hope our future legacy to be. Meaning-centered therapy is very structured. It is either 7 or 8 sessions. And you can see here that each session has a different kind of topic and then comes with specific content, starting off session 1 with reading Viktor Frankl's Man's Search for Meaning.
So, how are we tackling this here at the main campus? So, starting in January, Dr. Brandt and I developed the Palliative Care Mental Health Clinic. So, where we are currently, this is a collaborative care model within our palliative care service line. It consists of a interdisciplinary team of a psychiatrist, myself. I operate on a outpatient consultative model. So the way that I see my role is the palliative care providers are managing somebody's mental health symptoms, and if they get to a point where they feel stuck and they don't know where to go next, they can refer to me, and I'll see the patient for anywhere between 1 and maybe 4, 5 sessions, however long it takes to come up with a reasonable treatment plan. Sometimes that can consist of starting a new medication. Sometimes it is the gradual taper off of something they've been on for many years and starting them on something else. Whatever really is outside of their comfort zone in terms of prescribing. And once a patient is stable, I hand them back off, and the palliative care provider will continue with that treatment plan. Then we have a psychotherapist, Dr. Brandt, who provides individual psychotherapy and also special population support groups, such as our LVAD patients. We have our chaplain, Tiffany Lyon, who I think is on the call. She runs a monthly grief support group and does frequent personal check-ins with patients and families for spiritual support. And then, of course, there is the palliative care provider, who's the patient's primary provider. Where we're going. So we're hoping to transition from a collaborative care to a more integrated model, addressing mental health needs embedded within the palliative care workflow, where each patient will be screened for mental health symptoms during their initial visits. The tool that we're planning on using is going to be the distress model that Dr. Brandt mentioned earlier. This will identify needs from first point of contact, and there you see the distress thermometer. We're hoping to create a structured, evidence-based approach to how we manage or address the mental health needs of our patients. This will consist of psychotherapy, where we'll be implementing the examples that Dr. Brandt mentioned today, more acceptance and commitment, dignity therapy, meaning-centered therapy, which will be potentially provided individually and possibly in group settings as well. We'll be tailoring a more structured approach to spiritual distress with the help of Chaplain Lyles to address those needs of our patients. And then lastly, come up with a standardized way of addressing the psychosocial needs of our patients by identifying resources that would benefit them. Again, using the distress thermometer as a kind of a guide. This could be helpful with financial means, food insecurity, providing information for local food banks and or transportation, how they can get a bus pass, and so forth. So in summary, unaddressed mental health needs are associated with a decreased quality of life and an increased desire for haste and death. There are many challenges to mental health management that contribute to these symptoms being under-recognized and undertreated, and there really should be more collaboration with mental health professionals in order to address that gap. Any questions?
Barley, thank you so much. And Kaylee, that was excellent. We really appreciate you doing that.
Thank you for having us.
Yes.
Before everyone signs off, though, I want you to know, I think Marquetta may have more to add about this, but if you put your email address in the chat, we'll be able to respond to you and get you your CME. And also, if there's any questions, please chime in right now.
You want to sign in the chat box with your email address and your discipline.
Thank you.
Yeah, do that before you sign out. Barley, how many patients are y'all seeing in this clinic currently?
So currently I am doing 2 half days a week, Tuesday and Thursday mornings, and I'll have 3 1-hour blocks.
Okay.
And Kaylee, I'll let her speak for herself.
I have a full clinic 5 days a week, 8 to 4.
Yes, you're doing the heavy lifting with the counseling.
Well, what it showed is like how invaluable and needed Barley's role
Oh,
is, and being
absolutely.
able,
Absolutely. It's a wonderful collaboration. Yeah.
it's been exciting. It really has.
In Chaplain Alliance, how often are you offering the support groups?
I have the grief support groups are monthly, the second Wednesday of every month, and it's open to the community as well as employees here, as well as families of our patients. That's once a month. It was last night.
And how many people are attending?
Anywhere from 1 to 8. It's an open grief group, so it's a kind of a drop in to fill in that gap for those other programs that are out there that have that obligation responsibility, like an 8-week or 13-week program. So this is more of a drop in. So people come in with different varying degrees of grief and timeframes from their loss. But we have a lot of repeat people and new folks. So it's we believe it fills that little need in there and niche. So that's why it doesn't tend to be a consistent number, but we probably average about 4 every month.
Looks like there was a question in the chat from Clarissa Reynoso about whether we have plans to integrate this model into pediatrics. Well, I mean, that would be lovely if we could do that. Our goal is to create a protocol that can be reproduced at any large palliative care institution in the country. So once we finish finalizing this model, everything will be standardized and structured. So someone will have the distress thermometer. There'll be somebody who helps filter what areas of the program they need to enter, whether or not they need to see Tiffany Lyons for spiritual support, whether they need help with the resources and plugged in with case management, therapy, and of course, medication management. Not every patient is going to need all 4 of those domains, so they'll be filtered based on their individual needs. And then at that point, everything again will be structured. So from a spiritual care standpoint, there will be 3 appointments, that initial screening and assessment, and then some interventions and support. From the psychotherapy standpoint, we'll assess whether or not acceptance commitment, meaning-centered, or dignity therapy is most appropriate. And those will also be a set amount of appointments that we will follow. Each of those appointments, in theory, the goal would be at some point to have a dot phrase that then will be outlined in this booklet and really can be taken up and applied anywhere. Most of the research that exists currently within this field is, first of all, lacking, but related to adults. There isn't much existing right now relevant to the peds world, but I suspect that there are ways that this could be tailored to address that specific population.
Barley and Kaylee, can y'all hear me?
We
Mhm.
can.
Okay, sorry, I'm a computer I'm not normally at and with no camera. So thank you all both for doing this and sharing the work time and time again that y'all are doing. For those groups that don't have their own Kaylee or their own Barley right now, can you just comment briefly on the reproducibility of this to involve particularly psychiatrists who don't have the palliative medicine background as well to be able to create something like this?
I think at least from a psychotherapy standpoint, before Barley joined, I had the opportunity to join this department and really build up the psychotherapy side. And what we can see is, I think it's about, and if we wanted to replicate this in another system, it's finding a licensed mental health professional who is passionate about the population and interested in doing clinical therapy. Because I think that it's almost like if you build it, they will come. And from a psychotherapy standpoint, it's about finding the individuals comfortable working with this population. And I know in the psych department, I think that's our struggle with psychiatrists, is that professionals not feeling comfortable.
And that being said, we now, since I started working here, have been getting a lot more psych residents rotating with us. And I would say all, if not at least most of them, once they get a taste of palliative care, one, are more comfortable with this population, and two, are actually really interested in lending their expertise and helping. So I definitely would recommend reaching out to whatever psychiatrists you do have access to, sitting down, having a conversation, explaining, how you would like their help. And I'm willing to bet that a lot of them would be interested, even acknowledging their own limitations when it comes to their experience with this population.
Kind of building on the replicability of this model. I mean, clearly it's exciting. I think it's very unique across the country. I'm curious, number one, a couple of questions. Number one, is this grant funded? Like, how are you paying for the service? And then kind of following up to that, how are you measuring outcomes, whether that's in terms of encounters or the 4 pillars that you mentioned, Dr. Halton, or other ways that you may be measuring outcomes? What does that look like?
In terms of funding, so in terms of psychotherapy, I bill the patient's insurance just like if I were in the psych department under general psych. So just utilizing the same billing codes that I would in psychiatry. In terms of measurements, that's something that Dr. Halton and I are really wanting to build out. I know my caseload or how many visits I complete each month and then by the year, but really wanting to incorporate some screenings on specific touch points so we can have that quantitative data on improvement of the mental health symptoms that patients are experiencing. Dr. Halton, do you have anything additional?
The only thing I would add to that is currently we're in the, I'd say, early mid phase of kind of building this out and still workshopping how it's all going to come together. We don't have any grant funding for the overarching project. However, we are in the process of, with the mostly led by our chaplain, Tiffany Lyons, applying for a grant specifically to help with the spiritual care arm of this clinic. Through I think it's through George Washington University, where they're looking to incorporate spiritual care in a more structured fashion into clinical workflows. So there are certainly opportunities out there. They're just limited right now with the limited amount of grant funding available.
Thank you. Great presentation.
One additional I think that's exciting, especially for this population, is the access. So being able to do both virtual and in-person therapy has really allowed our patient population who might be more homebound to still access the outpatient services, which has also been very helpful.
All right. Well, thank y'all. Thank everybody.
Well, if anyone has any follow-up questions, I'll put my email in the chat here. I'm sure Kaylee would be willing to do the same. Feel free to reach out to us.
And your slides will be available to anyone who's on today's call, if that's okay.
Yeah, no problem.
Okay. Thank you.
Thank you.
Thank y'all.